Hello everyone and welcome back to Clinical Cousins YouTube channel. Today we're going to go over the significance of the Q wave. So what we have to know right off the bat, it is good to memorize that a good Q wave is short and short, meaning that it should be less than 0.03 seconds in duration, and it should be less than 1/3 the height of our R wave. Remember, a good Q wave is less than 0.03 seconds long. It should be less than a small square, and it should be less than 1/3 the height of the R wave, meaning that we should not be able to fit 3 or more of these Q waves in our R wave. So normally a QS wave is generated in V1. This is kind of an aside, is that because there can be no R wave in V1, it can be a Q wave or it can be an S wave, right? We don't know because the nomenclature doesn't allow us to call it a Q or an S wave without an R wave. So we call it a QS wave. Now this is normal if it's found in V1, but if it's found in V2 or V3, it may indicate that an infarct is either occurring right at that moment or an infarct has happened in the past. So use caution if you see these deep QS waves in these V2 and V3. So now normally there's also some respiratory variation in the Q waves that we might see in our EKG. So normally the pericardium of the heart is attached to the diaphragm muscle, which I've drawn here in blue. This means that the contraction or the pulling down of the diaphragm muscle can alter the location of the heart, the physical location of the heart. So let's think about it. At rest, when the diaphragm is lifted, right? The diaphragm muscle is relaxed and it is closest to the head. Therefore, the heart is leaning at its normal sideways fashion. So, if we are measuring the heart's electrical vectors in this moment, we see that our Q wave, shown here in purple, is pointing directly at our lead 3. Remember, the Q wave, the interventricular septal depolarization, is pointing right at our lead 3. Therefore, the Q wave during exhalation will be larger. Now, if our patient takes a big inhale, right, the diaphragm pulls downward and it stretches the heart so that it's more upright. Now, the Q wave vector will be pointing more away from lead 3 and we'll have a smaller Q wave on our EKG. Therefore, we can see that inhalation, right, the pulling down, the more upright heart will generate smaller Q waves in our lead 3. So let's put it all together. If we can see a variance in the Q waves in an EKG, do we panic? No. We can predict that the largest Q waves will be during exhalation, right? And the smallest Q waves will be during inhalation. Now, what happens if we see Q waves that are greater than 0.03 seconds long, or Q waves that are very deep or longer than 1/3 of the height of the R wave? We say that these are likely pathological Q waves, or Q waves that indicate a pathology, or that these Q waves indicate that there is something wrong with your patient's heart. Now, these Q waves may indicate a past myocardial infarction, but a good thing to remember, a good clue, is that if we also see ST segment elevation and or T wave inversion, we should watch out because the patient is likely having a myocardial infarction as we read the EKG. Now, what have we learned today? We have learned that a good Q wave is short and short, meaning that a good Q wave is less than 0.03 seconds long and or in duration, and it is less than 1/3 the height of the R wave. We have also learned that a bad Q wave or a naughty Q wave or a pathological Q wave is greater than 0.03 seconds long. Remember, this is the most important one out of the two. And it can be greater than 1/3 the height of our R wave. We've also learned about QS waves, that they are normal in V1, but if we see them in leads V2 and V3, it can indicate an infarct. And we've also learned there's some respiratory variation with the Q wave as well. Remember, during exhalation, diaphragm is pushed up, the heart is more angled. The Q wave is pointing directly at our lead 3. And during inhalation, we stretch the heart, we make it more upright. This Q wave vector fires away from our lead 3. So if we see varying Q waves, we can predict the inhalation and exhalation by looking at the Q waves. How do we do this? We know that during exhalation, the Q wave is directly pointed at lead 3, so we'll see deeper Q waves during exhalation, and during inhalation, we know that it is not directly pointed towards lead 3, so we will see smaller Q waves during inhalation. Lastly, please remember, if you commit anything to memory, that a pathological Q wave, meaning a Q wave that is greater than 0.03 seconds in duration, or that is greater than 1/3 the height of the R wave, along with ST elevation and or T wave inversion, indicates that there's been a MI. So, as always, thank you for taking the time to learn with us today, and remember to like and subscribe for more content.